Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. All right. So in keeping on the trend with our mid-level providers and just other people on the ortho team, we have a CRNA with us today. Emily.
Hello.
Welcome.
Thank you.
Yeah, so Emily works in the operating room setting. So Emily, I'm going to ask you to kind of introduce how you got into the role that you're in.
Oh boy.
Yep.
Okay. Well, I kind of stumbled upon CRNA. I found out about it in my pharmacology class in nursing school, actually. Found out that it was an actual thing. I didn't know it existed prior to that. So I started off my nursing career in the ER and then knew I was going to go to grad school at some point, had planned on going to nurse practitioner school, and then realized that I couldn't live in DC and afford to go to school. So I moved to North Carolina back when it was affordable.
Yes.
Yeah.
Yes. You mean North Carolina, not nurse practitioner school? Because we found out last week that is affordable.
Correct.
More affordable than PA school, at least, it seems.
Yeah. So I moved here. I worked in the ER here, and then I moved to get critical care experience, which you have to have for CRNA school, which requires you to go to an ICU of some sort. Could be pediatric, could be cardiac. I did open heart. And
of course you did.
Of course I did. Because I went from a level 1 ER to open heart, and I was actually a little bored, but I learned a lot. And then I kind of applied to school after 2 years of that on a whim and got in. And then I was like, oh, crap, what am I going to do now? So then went through school. So back in 2010 is when I went to anesthesia school. It was a 2-year, 6-semester straight program. Where you come out certified after boards as a CRNA and you have a master's of science in nursing. The academics have changed since I went to school. It is now a 3-year program and you come out with a doctorate.
Oh, I didn't know that.
Wait, is there like a grandfather situation?
Yes.
Okay.
So there's a grandfather for the academia. The clinical hours are the same. So you can imagine I had to cram all that crap in 2 years. It really sucked. 3 years would have been
manageable.
Quite manageable. Yes, it would have been manageable. We got, like the 4th of July day off. We had Christmas Day.
so kind.
Eve. Yeah, so kind. We had 2 weeks of sick time over the course of 2 years. So
use it wisely.
Wait, did sick time equal vacation time?
There was no vacation time.
Okay, so you were sick on vacation.
And if
or
you went over the 2 weeks, you had to make up the clinical hours on the weekends or other such times. So anyway, you finish the didactic portion of it, and then as long as you've met your clinical hours, then you can sit for your boards.
Wait, pause. So 6 semesters all were academic, or it was 3 academic, 3 clinical?
Yeah, so there's different programs. Programs like Duke, they do all of their didactic up front. So they do all of their classroom stuff up front. And then their following years are all clinical. Mine was integrated, so I had 3 months of didactic, which are not enough to give anesthesia. Yeah. And then you start clinical and class at the same time, 50-50.
I like that.
50-50, 50-50. Yeah. Mm-hmm. And that actually was quite nice. They tried to match you up, because then you have specialty rotations where you do neuro and cardiac and OB and peds and all those things.
Yeah. So with the new requirements for it, so the background is like, do you have to be a nurse to apply to CRNA
100%.
school?
Yeah,
Okay.
you have to be a nurse.
So you get your BSN.
You have to take, I took the MAT back then. That's how old that was. But now you have to do the GRE. And you have to have, I think they've lowered the amount of experience. I think you can go in after, it depends on the program, 1 or 2 years, critical care. Mine was 3 to 5-ish. And so I got in with my open heart and level 1 trauma center in DC.
As you should.
So, as you should.
Yeah. That's I haven't even seen your resume, but I'm already impressed.
Yeah, it sounds fancy. I think I was just an adrenaline junkie, truly. I mean, I did EMS prior to that, so I was like, yeah, let's go do this.
Yeah. Was it hard to get into CRNA school?
Yeah. There were I went to the UNC program, which at that time had a satellite office in Raleigh. There were around 600 to 700 applicants. About, I think it's 100 to 200 get an interview.
Okay.
And then they take 32.
Oh my God.
Okay, yeah.
That's
more
like,
competitive PA.
yeah,
It's
really
pretty competitive. I don't know about now. I know it's a lot different now. And I know it's a lot different about the amount you can borrow for grad school. So I know it's a lot more expensive now. But so you would go and you sit in front of a panel of 7 people, the dean of the school, an anesthesiologist, 2 CRNAs, and then the 2 clinical directors of the program. So it was very intimidating.
Do they interview you based on like your experience in nursing, or do they like give you scenarios?
Both.
Oh, yes.
Yes. So they're very specific.
I like that.
I do too.
And I think that's when I developed hypertension, was sitting in front of the panel of people. There were questions about, and they were relevant to what I have done as experience. So they talked about balloon pumps and a lot of pharmacology, right? Because CRNAs supposed to know everything about pharmacology. So, and they talked a lot about cardiac drips. I was put in scenarios where was there a protocol or rule that I went against for patient safety? Always hard questions when there's no right answer.
Has that happened to you in like when you were a nurse?
Yeah.
Yeah. Okay.
For sure.
Okay. So you were like, hold my beer.
Yeah.
Okay.
I've got like 10 in the back of my head. Because I mainly work nights.
Random question. What were you wearing during your interview? Because I asked that because during my PA interviews, I wanted something dark because I was going to sweat my ass off. Because I was so stressed out about what I asked. Like the armpit situation is what I'm basically talking about.
Oh, God. I think I wore all black. It looked like I was going to a funeral.
Oh, man. You guys wore all black? I wore a white shirt.
No, of course you did, Hannah.
Yeah, of course you did, Hannah. No.
Were you in like awkward or Mana State, Hannah?
Yeah, Hannah wore pearls too, you jerk.
Yeah, I did like a Hillary Clinton. I had like a pencil skirt suit.
Jeez. You totally see. Yeah, that's not what I would guessed. Yeah, I think
not even the pantsuit.
Yeah. I wore a black, like, I don't know, something situation. I just remember thinking to myself, like, I'm gonna sweat and no one's gonna know about it. I'm gonna feel very good about it.
Yeah, it's gonna be great.
Yep.
Yeah.
Cool. Good. All right. So fast forward to you take your boards. So we talked about this last week with nurse practitioners and PAs. So PAs have to take their boards every 10 years. Is that something that CRNAs have to repeat, or are you one and done?
Yeah. So it has changed a couple times. So I took my boards in 2012. I retook them in 2022. Yeah. 10 years later. But they have since, I think, changed it to, instead of doing the boards, they're doing research as like you're in this clinical setting, right, for 10 years, and then you go back and you have to do this academia portion, and a lot of it isn't relevant to what you're doing currently.
Yeah.
Especially if you're specialized. So what they have changed it to is every quarter, there are 30 questions, and you have to finish every single quarter, meaning so 4 times a year. I take 30 questions. And on top of that, there is a lot of continuing education hours. And they recertify those within a 4-year period. That's how they do it. And I think it's 120 hours. And it's part of it is academia and part of it is clinical.
Yeah, that's very similar. So the PA program did the same thing. They recently changed, well, you can still go to the classroom, but it's actually your option to sign up for the quarterly live. Mm-hmm. So it's like more like a living study situation as opposed to cram and then take your test and then not think about it for another 10 years and do it again.
Yeah. This is interesting because I feel like the CRNA pathway is like more similar to the PA pathway than nurse practitioner
100%.
Was to us, even though the rules for nurse practitioner are like more similar. But yeah. Obviously we have very different like kind of roles with our supervising providers, and we can talk about that.
In the operating room, and specifically speaking to the surgery center that we all collectively operate out together, okay? So being a CRNA, at least in this setting, let's say ideally there's a supervising anesthesiologist that's on site for the day, and let's say there's 1 or 2 CRNAs, okay? So in my head, and again, this is as mid-level and also not a CRNA, I'm thinking the anesthesiologist is kind of setting the tone for the day, and the CRNAs are working collaboratively and collectively to get the job done. And I've seen it work like that, and I've seen it not work like that. Mm-hmm. For example, okay, let's say, the start time is 7:15. It's when the first case is supposed to start. Now there's a couple rooms. So first case to start means 2 cases are going to start. So that means everybody has to be there on time. the preoperative nerve blocks are getting going, and then we're rolling back at that time. Emily, does that always happen?
No.
Okay, now
Why?
care to enlighten us as far as various scenarios that would make it, it's from an anesthesia standpoint, why that won't go accordingly.
Yeah. So in a setting like this, okay, so early is on time, number one.
Yes.
Right? And the anesthesiologist actually has to get here earlier than, say, we would. So, yeah, that doesn't always happen. If the anesthesiologist is late, generally we will not be in the room on time. If a CRNA is late, same thing.
So whose job is it to like pick all that stuff and get, like, let's say you arrive on site and you're like, all right, let me see what I got today. All right, I got 2 shoulders in one room and 3 knee replacements in the other. Like, whose job is it to say, like, okay, we're going to do this block first? Is it very much specific to who the anesthesiologist is? Like, does personality play a role in who decides, like, what's going on or who's doing what first? Like, how do you play a role in that? Are you like, hey, we should go, it's 7:12 and no one's done anything? Or do you kind of like passively, which again, I know the answer to this, sit back and wait till the anesthesiologist decides it's time to start?
Yeah. So I think a lot of it is the attitude of the anesthesiologist of getting to work on time. Typically, for the ambulatory surgery centers, we get the schedule the night before.
Okay, so
they know.
Okay, so there's the baseline understanding that they know what they're walking into.
Yes.
Okay.
And if they show up late, you're like, oh, okay, you're late. We're all going to be late now, right? I typically will finish, setting up my room. I'm out there usually around 7:05 to 7:10, getting ready to roll back. And whether my patient is ready or not is a complete other story.
So you've got your job of setting up your room, but you are very much dependent on your next step as far as the anesthesiologist does. So can you describe a partnership that you like show up and you know that you got this person today and you know you're going to be on the same page versus you have this other person and you're like, oh God, this is going to be a rough one.
Yes, very true. So yeah, when I'm with the typical anesthesiologists that work here, I'll go into that example. I know that everything is going to be run correctly, and so I do get here quite early. Actually, before I clock in, I generally will get here. If it's an anesthesiologist that I have never met, there's a question of whether you just show up on time or really early just to make sure they know exactly where everything is and those type of things, because you never know if they've been trained or oriented correctly. Training and orientation in a very small facility is kind of non-existent for us. So and then there's some that just have, they got a little trouble in the morning waking up, and they're just gonna be late no matter what.
God, that's so frustrating.
It's
so frustrating.
You chose a career that was an early morning thing.
So what is overstepping in your case versus what is just going with the flow and kind of like falling in line?
So I think for this type of setting, it's go with the flow. However, those times of when we get in the room late and they look at the anesthesia record, right? Because, you got in the room at 7:22. Why? And then they'll ask me 6 months later and I'm like, I have no idea, right?
Yeah.
So what I'll do is I will write a note in the chart. I will say block complete at 7:20. And then we get in the room at 7:22. That means it took me 2 minutes to unhook this patient from a monitor, get all of my paperwork, and get them into the room. Same with surgeons. We'll get in the room early, and then they won't show up for like 30 minutes. I will write a note in the chart. Oh, Dr. So-and-so, arrival in OR.
Yeah. Isn't that like that, I assume from your perspective, is also very frustrating. So say like you're getting pushed to like, let's go quicker. Yeah. And then you stand around, everything's ready to go, and you're in there and ready. And you still stand around for another 5 to 10 minutes. Yeah.
And I think I've just kind of learned this because, there is this saying that anybody in surgical services, you can just blame anesthesia for everything, right? And the first person that you're going to see is likely me. And so having a little bit of a backlog, a little written trail.
Yes.
Is also nice because I'm like, no, actually, block wasn't done until 7:20.
I love that too. But is it appropriate for you to collectively assume anesthesia is to blame, to know that it's the anesthesia process, meaning that's you and then that's the anesthesiologist? Or are you very much like, no, it was Dr. D who totally effed up the day.
Yeah,
like what's
not me.
like what? Or is it like professionally where you say, I'm sorry for the delay. It took a while to get the patient in the room, which is insinuating that once they were in the room, we're rolling.
Yeah.
I mean, like that's the professionalism in there, right?
Yeah. And yeah. So we are contracted, right? So we are not employed by, there are some CRNAs and anesthesia groups that are employed by the hospital, but not as many as that are contracted, right? So as contracted staff, you're going to have to grease the wheels a little bit. And just be very professional. I'm so sorry this happened.
Yes.
In the back of my head, I know this was pre-op and they couldn't get an IV and they tried 4 times and then I had to go in there and put it in the foot. And then I'm like, oh my God, I'm so sorry. So sorry. It's like, this is totally my fault. I'm so sorry.
Yeah.
Okay. So I'm going to draw a parallel there for a second. I do think that there's a lot of situations in the clinic side in MD-PA world where we also have to do that.
Yes.
Let's say the physician is behind. And again, I'm like kind of really highlighting like the time thing, but it's not always that. Let's say the physician was really short with a patient because of whatever circumstance. And then you have to kind of go in and sweep up, bring in the old vacuum and smooth it over. And I think it's really important to like maintain face as far as a collective unified front is concerned. But like in my soul and in my head, I'm like, I'm not the one you have to blame here. Okay. I'm not. Like outward, I'll say, yeah, I know. I'm totally apologize for your experience. We'll do better next time. I really appreciate the feedback. But like in my head, I'm like, it was the front desk, mother effer. Like it was. And it wasn't me. And I need you to know that, you know.
Nothing to do with me.
Nothing to do with me.
But you will take the blame for it.
Yeah.
So you get blamed for a lot of things,
everything.
Right? Okay, let's start with that. Let's break that down. Okay. What is
So as specific to ortho, I'll say that first. There's a very funny anesthesiologist that makes these YouTube videos of stick figures, right? And there's one where there is a fracture. I must fix it. It's the ortho surgeon, right? And then he's like, the patient has a condition called asystole. And then the anesthesiologist gets on. They're like, yeah, we're going to have to cancel this case. He's like, but there is a fracture. I must fix it.
Right.
He's like, well, the patient's dead.
Right.
So
it's like, but the bone's still broken.
Yeah. And you are preventing me from doing this case because the patient clearly has a fracture and must be fixed.
Yeah.
Like, well, the patient's dead. So, very funny. I love those. You should watch those on YouTube.
Yeah.
Anyway, but yes, I have been blamed for a multitude of things. And it has become so comical, in fact, in our profession that there are T-shirts made. And actually brought one today. So I'm going to read just a few.
It's amazing.
Reasons why to blame anesthesia. The room is too hot. The room is too cold. Global warming. Global cooling. Trump's hair. The bed won't go down. The bed won't go up. Miley Cyrus's life. 23-year-old G6P6, which for any of the OB people, you know what that is. The patient's INR is equal to the patient's age. It's always fun.
That's not a good thing.
It's not a good thing. No, that spells death. Yeah. The patient no-showed. We get that one a lot.
Yeah.
Like you scared them off in pre-op. Like they come in for pre-op testing. And like we do like an EKG because they're 50 and they're giant.
It's required.
And they have hypertension and they have high cholesterol.
Yeah.
They've never had well, you scared them off by doing this test. It's totally your fault. Yeah. The patient ate in the ER. We get that a lot.
Yeah.
Well, you didn't go down and pre-op test them.
You
so
didn't tell them not to.
We get in trouble if we pre-op test you.
Yes.
And then we get in trouble if we don't. I tell you not to eat. That's fun. Yeah. The people of Walmart. That's one of my favorites. Yeah. Circulator no-showed. Because we can control the staffing, right? The OR radio is broken. I get that one a lot. Not here so much because you guys have radiology. I can throw it on.
Right.
But, 4-hour lap choles because we didn't have the patient correctly paralyzed, obviously. It must have been that. The Kardashians, Tupac and Biggie. The diaphragm moving. That's my favorite. My favorite is when they don't want the patient to go all the way off to sleep. They want them breathing. They just want a MAC case, right? And so we give them sedatives, and then their chest is moving because they're breathing. But the chest is moving.
Which is a good thing, though.
Yeah. And they're like, well, can you make it less? Well, yeah, I could. That means they're not breathing. Yeah.
Less alive.
That's great.
Yeah, but I need you to do all of what we need. And make the chest not move, but allow them to breathe under MAC.
Yeah.
And then you say, okay.
Sorry, that's my fault.
Now, do you think your relationship with your supervising physician or anesthesiologist, like that is a collaborative thing where they would then jump in and say, it's not our fault. And then have that conversation of like, let's say anesthesiologist to surgeon where they're like, hey buddy, listen, or do you feel like you're just on an island by yourself, just saying things?
I think there are very, very small number of specific situations in which the anesthesiologist would probably come in the room and stick up for us. One of them would be blood pressure, especially with ortho. These people come in and they have, their normal mean pressure is like 110, right?
Yeah.
And then you don't really want to drop below 20% of that. And so, their blood pressure might be 130 over 90, and that might be the lowest they can go because they normally are like 190 over 110. Mm-hmm. So when that happens, and I'm like, well, I'm not going to drop the blood pressure that low. Yeah. Because the ortho surgeon refuses to use a Bovie and there's too much blood loss, right? Yeah. And they can't give like 15 grams of TXA. So that's when I would call the anesthesiologist and I'm like, well, you can argue with him about it. Yeah. Yeah. And then they go at it.
Well, that's great. I feel like, but that's weird that would be a few and far between, don't you think?
Few and far between.
I know. But that also, I think for the benefit of you and who you are and your personality, I think that allows you, though, to also stick up for yourself. And when you strongly believe that something is true and the way it should be done, you have no problem saying, this is how it should be done.
Yeah. 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 Because you're like, well, you might get through this procedure, but your patient's probably going to stroke. Yeah. Or have hypoperfusion complications or,
Now, do you think, and again, you've done this, you said 2011, right?
12. So I've done CRNA for 13.
Okay. 13 but your interaction with physicians nursing before that has been 10 plus years, right?
Yes.
Okay. So do you think early on in your career, you would have handled a situation like that differently versus now where you have no problem just doing what's right for the patient and advocating for yourself essentially?
Yeah. So CRNA school does a really good job of making you have super thick skin. Also PTSD, but we won't get into that.
Yeah. Separate
issue. But yeah, thick skin is definitely, it's like a requirement to do anesthesia, which, it just kind of comes with the territory, right? You have, when you're a younger nurse and you see these surgeons or, these doctors and you forget that they are just people. Yeah. And that they're not God and they can't, reign over whatever. Yeah. You're much less likely to stick up for yourself and just kind of, do whatever's written down or whatever. But yes, my personality kind of from the beginning is, I'm like, no, we're not doing that.
We're not doing that. Yeah. And I've been witness to that before. Yeah. You did a very awesome thing over here for a patient that had malignant hyperthermia.
Oh God.
And where you were in the room controlling the patient, kind of realized that something was happening that was not supposed to happen and kind of flew into action very quickly. And I think in that situation, it was Vince, right? Who was here?
Yes.
Okay. And he supported you and also 100%. Let you 100% run the show.
100%.
Yeah. So talk about that a little bit. I mean, and that's again, situations like that, although terrifying and frightening and everything like that, I mean, that also is why you have the credentials you have, because when push comes to shove and when there is something that requires your attention, you're not going to stop and be like, excuse me, I need supervision and help and permission to do so. You just do it and everybody sits back and they're like, she's got this. Mm-hmm. Yeah. So talk about that. That was cool.
I don't want to talk about my PTSD. I just said that. I'm just kidding.
Okay. Well, anyway, it was a great event. Moving on.
Yeah. So the worst thing, not the worst thing, but one of the worst things that can happen in anesthesia is malignant hyperthermia. And it is extremely rare. Most providers will not see it in their whole career. And I was hoping not to, but I did. And it was as soon as I left doing open heart at the hospital, go figure, out here in no man's land, as I call it. Patient was a typical soccer mom, real skinny. Probably drives a white SUV, goes to the Chick-fil-A drive-thru. That kind of lady. Wait, just paints a picture.
Is it you? Hey, wait. Okay, my car's not white.
Okay.
Anyway, yeah. So she was. She broke her ankle, and healthy other than her osteopenia. So she had a lot of other surgeries. This was her 4th surgery. And generally with malignant hypertension, could be 1st, 2nd, but this was her 4th. And so this was nowhere near on my radar. But yeah, it happened. It was also delayed onset and 62 minutes in. And I know that because we had a tourniquet on the patient.
And you remember that because you're good at your job?
Yeah. Yeah, the things you remember in emergencies are kind of baffling. You know, you can clear as day pull it up.
But also, to be clear, your prep for the case is you don't just show up, go in your room, and you're like, hey, ready to go. Like, you know this patient. You've gone through the chart, you study. You want to know, like, what are the issues? What should be on your radar? And even after that, this was not on the radar. Not because you didn't do your job or no one did their job. It's just because this was not, there were no risk factors that this lady had, right?
Right. This lady had no risk factors, nowhere on my radar, being the fourth surgery. They do have paper charting here, so it is kind of hard to look back at the electronic records that she's had in the past. But so, and I just had the anesthesiologist had just been in the room with me, and because she started breathing, you know, quite a bit, and all of her vital signs were totally normal. But you know, she's a little wino. She was tachycardic and pre-op, and I gave her, you know, a good bit of narcotic, and so I actually called the anesthesiologist in just to talk about, you know, giving a longer acting one. And so he just saw the patient, but before he walked back over to the staff room over here and sit down, shit went haywire.
Yeah, hit the fan.
So I called him back before he sat down. And in the time that he walked over here and came back, I had literally taken apart the anesthesia machine, because it's got to be that, right? It can't be the patient.
Yeah, no.
It's got to be a machine. So I literally took apart the anesthesia machine, put a new soda lime absorber in and everything else, and had turned off the gas at that point and changed to propofol drip when he walked in. And he walked in, and I was like, this is what's happening. Because I'm still not entirely convinced, right?
Mm-hmm. Yeah.
You try to, you know,
well, it's rationalization.
So rare.
Yeah, it's rationalization. You're like, this isn't really happening.
Yeah.
Yeah.
And then, and he's sitting there, and I can see his, you know, the squirrel on his wheel.
Yeah.
He's or hamster, whatever it is. At that point, probably a raccoon, because everything was crazy. But he was just running and running, and he was like, I was like, do you want me to get the MH card? And I like whispered it, because like, of course that can't be it. And he goes,
Yeah, but he's thinking it. You're thinking
he's
it.
thinking
But
it too.
you actually just said it out loud.
Yeah.
So now it's real.
Yeah.
do you want me to get the MH card? And he's like, I think so.
Yeah.
And so I like ran out here, and then I freaked all the pre-op out, which was great. And then I brought everybody back with me, and we did our thing. But you know, MH drill, you're required to do an MH drill every single year in any facility that carries a volatile anesthetic, which is a gas, or succinylcholine. There are some cases in which that paralytic has caused it. So, you know, we've done this drill forever, and I was just hoping never to use it in actual practice, but we just followed it, and it went okay. And the patient did well, thank God. But even with prompt treatment, they still have a 50% mortality rate.
I know. That's crazy. And this lady, like, spoiler alert, this lady did just fine. So saved her life.
Yeah.
Ugh.
Yeah.
I never want to see her again.
Yeah, no, I get that. No. That's the PTSD talking. That's the PTSD talking. Yeah. No, but I think in that situation, I think what's important to highlight is that, you know, you're in the room, you're kind of in charge with that patient at the time. Yes, there's a supervising physician on site, but you recognized, you kind of called the code. I mean, I don't want to call it code, but like, you called that process, and nobody questioned you. Yeah. Everybody was like, yeah, no, this is happening right now. Yeah. So that, again, that's a you thing, but also that's why we do what we do. Like, you know what I mean? So you say you're an adrenaline junkie, which you are, but 100%. Yeah. But I also think that there is some serious, deep satisfaction in providing the care that you do and having these positive outcomes. So
I also would want an adrenaline junkie taking care of me if something like that happened. Like, I don't want somebody that's like,
yeah. Like,
or like their triceps look like they can't do CPR.
Yeah,
I don't want that.
Yeah, no. They've got to have that mindset.
On a side note, just from that, I do think for PA, NP, or CRNA, it's very important your first job to be something like hard.
Yes.
Do something difficult.
Yeah.
Do several years of something difficult, and then everything else will fall in place, and you'll be much more confident about
that's true.
Your practice. So
work in the ER a little bit.
Yeah.
Yes. That taught me just about everything I need to know about humanity.
Yeah.
And anything having to do with medicine.
What's your craziest ER story?
Oh, God. Well, I had two, actually. I had one clearly gang member, but no, this was in D.C., so put that in perspective. But he walked into triage, which is behind bulletproof glass, and I'm looking at this man, and he turns his head, and there's an 8-inch Bowie knife hilted into his head.
Oh.
Walking into the ER. And I was like, and I just kind of paused for a minute, because I thought it may be one of those like Halloween things with the hat. You know what I mean? Like,
isn't it funny though that like your eyes will tell you something that it will make up 50 other things other than what it is. Like when the guy looks like he has a knife in his head, guess what? He does.
He does.
Right? Like they might have
Your
had
gut
a cool
instinct was
hat
correct.
on that day that showed that it was that. But I mean, it's just funny what your brain tells you. Like, let me just find out if that's a hat. Hey, sir, is that a hat?
Yeah. Yeah. So he went back real quick, right?
did.
In a wheelchair, obviously. But, yeah. And the charge nurse was like, there's no room back here. I'm like, you're going to make one. I'm not putting this man in the triage. And the second one, which is a little bit more harrowing, was I had a 16-year-old girl, and I will never forget it. I was 6 months out of nursing school. And you know when teenagers drive with like their leg up on the dash?
Yes. You told me this one.
So there was a bad wreck on the highway, and she did that coup contre coup. And broke her femur, avulsion fractured. And then when she went forward, she actually impaled her head on her own femur.
Oh.
And so I had to pull a femur out of a girl's head.
That's also not a figure of speech.
Yeah.
Yeah.
She didn't make it, obviously. But So when I don't let my teenager ride with anybody,
Yeah.
that's why.
Yeah.
You think about those
And that's
things.
not really an example that he can argue against.
Yeah.
So that makes sense.
I'm like,
Yeah.
I
Makes
pulled a
sense.
femur out of a girl's head. So
Yeah. Yeah.
That's a good one.
Yeah. That one stayed with me.
6 months in too. Yeah.
Yeah, yeah. I got all that.
Starting really strong.
All that craziness first 3 years. Yeah.
What do you how would you describe like your working relationship with PAs? Like, do you feel like working with a good PA or a bad PA makes a difference from your perspective in the room?
Or what do you think of PAs?
What do
just
you think
in
of
general?
us?
Like, what are they?
Do you like us?
I mean, I do, especially like the two that are currently sitting with me. Yeah. So I think for a CRNA, and I'm going to say experienced PA, NP, whatever have you, right, are 100% our ally.
Yeah.
Because you are a direct line to
Yeah.
a surgeon,
Yeah.
doctor, whatever it may be. PAs also play like a significant role in cardiac surgery, where they harvest the saphenous vein. They round on their patients. Cardiothoracic surgeons are great at what they do, but they don't deal. There's a lot of stuff that goes on in the background. So tight knit with the cardiac PAs, and NPs as well. Same role, same type of relationship. So for us, you guys are like great. However, when you guys are training a PA student to suture on a Friday afternoon, and it takes an hour when it should take 5.
No.
I didn't.
I want to reach over the drape and strangle both of you.
Yeah, no, I get that.
But that's it.
Yeah. So do you think there's this, do you think that there's this unspoken level of respect for mid-levels? Like you look through the drape and you're like, I know you're doing everything that I would do right now if I were you. And it also is like, at least in this setting, like we're all here to coordinate, get the job done, get it done efficiently. And when you're kind of firing on the same cylinders, I mean, we lock eyes, what's happening.
Yes.
Whereas if you have the opposite, like PA, CRNA or CRNA PA, where you see the other person is just not locked in for the day, like it goes from 0 to 100. Like it's like a disappointment thing. Like you're better than this. Like I expect more out of you than this. Right.
Yeah.
I would expect Emily to like kick me or something if I was
but I also want to make like that person, I want to make their job easier. Like it is like from a PA perspective, you want to make the whole situation flow better and the surgeon's job easier, but also your job easier.
Yeah,
and I feel like there's
help each other.
Yeah, there's an unspoken,
camaraderie.
Whereas the CRNA is like, hey, we're going to roll back. And then you tell me, you're not telling the surgeon because you know that I'm going to come in the room and get the patient ready.
Yeah.
I just think that's funny. And when you're off, like there's not that, you don't have the same expectations for the day. It creates another level of friction, like in the room, and there's enough reasons to have friction in the room. There just doesn't need to be that. Yeah. Like if there's a student on a Friday afternoon.
Right. I will add though that, most of the time, in the grand scheme of having surgery, you're not going to die from the surgery. You're more likely to die from what we're doing, right?
Yeah, yeah.
And the 2 times that may occur, most likely, is on induction, going to sleep, and waking up. And guess who's in the room with us?
Yeah.
The PA.
For both of that, yeah.
And so I've had many a time where there was a code with just the PA in the room, or the NP, as well. So it just kind of strengthens it, especially in like a big hospital setting, because, we're the ones that are finishing the case. And to us, that is the most important times.
Yeah.
So.
Yeah. And you just have like this unspoken, you can communicate without talking sometimes.
Emily
and I lock eyes sometimes when things are happening.
Yeah. No, there's a whole conversation that happens.
I can read a full paragraph.
Yeah.
Because, we can only see each other's eyeballs, right?
Yeah.
Because we don't see each other in actual clothes.
Right.
There's a hat, mask.
Right.
Most of the time glasses.
Yeah.
And I can still see like how dilated your pupils are and how pissed off you are or how constricted they are. And you're like, you know, and I can read the full paragraph.
Yeah, you can still see what my face is doing under my mask, which is weird.
Emily calls it my manic versus I don't know what the other version.
Yeah, there's like calm Hannah, there's uncaffeinated Hannah, that's fun, and then there's awkward Hannah and manic.
Yeah.
Oh, I've met awkward Hannah.
Yeah,
awkward Hannah's super fun.
I told her about the mug.
The mug is amazing.
I should have brought the mug today.
You should have brought the mug. Now, do you think patients don't understand your role? Like, do you have that conversation with patients? Or when you say the word anesthesia, like anesthetist, like I feel like before I was in PA school and more so in the operating room, like I didn't know there was a difference, to be totally honest. And once we see what CRNAs do versus anesthesiologists in the setting, they do a lot of the same things besides the blocks, I guess. I mean,
regional is definitely where CRNAs are less a part of, right? So even in school, my regional rotation was significantly less than all of the others, right? So, anesthesiologists they definitely have kind of, lack of a better word, monopolized the regional part of anesthesia. So, I don't think patients, when you present yourself, hey, I'm so-and-so, nurse anesthetist, I don't think patients have the second to question it. Like it's a very known department of anesthesia, whereas I think there's more confusion in the PA profession. A lot of, they get a pre-op assessment, right, with an anesthesiologist. And so they assume that person is going to be doing their anesthesia in the back. And it's not always the case. We do have some docs that run their own rooms where they actually do the case. But for the most part, it is definitely a CRNA.
Yeah.
A doc can supervise 4 CRNAs at one time. So you could have 4 surgeries going on with one anesthesiologist. So you'll have 4 CRNAs. I think it's patient education, right? So when you introduce yourself, you could introduce yourself as a CRNA. You could say nurse anesthetist, or you could just say anesthesia.
Yeah,
really, if you don't want to get into it.
Yeah.
I usually say that if it's like a little old lady or somebody that's super nervous and they just like don't.
They're not the time to have the conversation.
They're not going to get it. Yeah.
Yeah.
But there's a little bit of a lack of understanding of what actually goes on in the back of an operating room, I think, for the layperson.
Yeah.
Well, they're asleep during it, so.
Yeah.
Yeah.
But you don't have like the patients that are like
they refuse
I don't
to
want
see.
you to do my anesthesia. I only want the anesthesiologist to do my anesthesia. Like, does that happen?
It has not happened to me. I have heard it happen.
Okay. It must be more rare, though, I would imagine.
It is rare.
Right?
Because in a hospital setting, that shit ain't gonna fly.
Yeah, you don't get
I would never,
but I would be like, well, we're gonna cancel your case.
Yes. Okay,
because
so
we
no
don't have
anesthesia.
that kind of staffing.
I would never question Emily, though. Like, if Emily came over and said, I am Santa, I'd be like, yes, you are.
I have a magical sleigh.
And I am okay with you providing anesthesia for me today.
Please do.
Yeah. Well, yeah. I mean, we're all a little different, but typically CRNAs are triple type A and OCD people, right?
Do you think, this is a question from last week, do you think you are a hyper independent female? Was that what it was?
I feel hyper independent.
Okay, I also had a problem with the word hyper. Hyper seems like it's too much.
It means like I have ADHD and not medicated enough.
No, like excessive. Like that's how I interpret it. Excessively independent, but we came to the conclusion it's not an excessive amount. We are appropriately independent.
Yeah,
right. Are you
more so than the general population?
Oh,
are you an above average independent
person?
I know where this came from. I know which doc said this. No.
Oh God.
Yeah.
No,
well,
but
one of our docs said that my spirit animal is a honey badger, so you can just mellow on that for a minute. But yeah, so
your mascot.
Yes, I think that
like for you to take on the level of responsibility that you do, do you think there is some innate personality trait that you have that potentially we all share for wanting to do the things that we do and pick the professions that we pick?
Yeah, I think the level of autonomy
Yeah.
You know, that we get, especially you guys, because you deal with a lot more logistical things than I do. Mine's more of a dire, I'm going to keep you alive.
Yeah, life or death. Life or death.
Life or death, right? Mine's just very dire. I sedate all my patients. I don't really have to talk to them that long, right? I don't have reviews. I want to talk about that, though.
I'll do your review.
But yeah, I think that inherently we are all very independent, most of the time outgoing people.
Have to be.
You have to be confident, because even if you're fake it till you make it, you have to instill confidence in the patient that, you know, I'm going to keep you alive for this.
Yeah.
When really, you know, you've never done the case before and you call every single friend that you have and you're like, hey.
Yeah. What would you do?
Right.
Well, I also think, though, that your, again, back to personality, I think your personality is such that you exude confidence. Like, you are a confident person. And I'm not sure if that is like you, because you've had all this experience and you've had all those PTSD experiences. Mm-hmm. Yeah. Okay. Yeah. So the answer is yes.
I think it's both.
Yeah.
I think I've always been fairly confident. I think sports actually played a big role for me. When I was younger and I played in college, and you kind of competing at a high level with high stress, you have to have some sort of confidence and, you know, gumption. Yeah. Right? Gumption. So there you go. That's a great word.
But that's also the team approach too. Like you know how to work on a team.
Right.
You know the unspoken rules of like when you are being blamed for something, like when it's appropriate to say, you know, hey, this is unreasonable, versus when you're just like, I'm just going to let this play out and I'm just going to keep face and apologize, you know, that type of thing. Mm-hmm. Yeah, I do think sports. How come we've never made that comparison before?
Take one for the team,
Hannah.
Isn't it? Yeah. Well, we could have a whole episode on that.
We do. We could. We won't today.
For another day.
So what advice do you have for nurses that are considering NP versus CRNA? Like what would you tell the newbies coming out?
Well, pre-COVID would have been very different than my advice now. What you don't want to be in a respiratory pandemic is an airway expert. I can tell you that right now.
Were you?
Uh-huh. Yeah.
Oh my God.
Anesthesia is definitely the airway experts.
Well, I mean, I guess I'm just now putting together that, yes, you were CRNA all throughout COVID.
Yeah, it was, and I was in the hospital, then I was on the cardiac team. So it was,
that's awful. A lot. Yeah.
Yeah.
That's crazy.
So, so CRNA school, the 2-year program, I'm glad they have phased out because it is almost impossible.
Did you work during your 2-year program?
No.
Yeah, couldn't.
Right?
It's like PA school.
Yeah.
There's no way.
And there are some hospitals actually that will limit your amount of clinical hours during the week.
Yeah.
Because it's not safe.
Yeah.
You know, which, you know, fair. So the 3-year program, from what I've been told, is there's a lot more, like they get a full break. They have time where they, you know, can decompress, work.
Yeah.
Right?
Yeah.
Because when I went to school, you could get loans for academia, but you could not, you know, I had a mortgage. I was single.
Yeah, that's crazy.
You know, I couldn't work. I'm like, well, what am I going to do now?
Yeah.
Right. So you had to pull out like personal loans.
Yeah. Yeah.
Right. And with the limitations now with grad school and the price of just grad school in general going up, I think it's going to be difficult in general. But I do think 3 years is much more feasible than 2.
Yeah, that sounds like much more manageable from a physical and mental perspective.
But, you know, having a year longer of that as well, oof.
Yeah.
Ooh, I don't know if I could have done that. I don't know if I would do it again. How about that?
No, I get that. Now,
I'm glad where I am now.
Yeah.
I don't know if I would go through that again knowing what it was. How about that?
Yeah. Okay.
It was
fair.
pretty rough.
That's fair. Yeah. Does your family, double question, does your family support what you do? And does your family, if I asked each of them right now what you do they know?
That's a great question.
I know.
The answer is no.
I know. I know. They don't. They have no idea.
So they were 100% supportive of me doing anything in medicine, right? And then apparently my parents, I'm like, well, where did that come from? Because I only have one other person in my family who's medical, who's a pediatrician. And they're like, you just came out that way. I'm like, oh, okay.
Okay.
Everybody else is an engineer and likes to shoot people in the Army. So, yeah, I'm kind of a, you know, black sheep. But yeah, my family has always been very supportive. What was the second one? Sorry.
If I asked your family what you do, would they be able to like define what
they
a
say
CRNA
I put people
is?
to sleep for surgery.
Oh, that's pretty
that's
good.
a pretty good
anesthesia.
answer.
Yeah.
Yeah.
I mean, that's about the limit.
Yeah, my dad still thinks
Yeah.
I'm like a dentist or something.
Yeah.
I swear to God, he still thinks I do something with like teeth. Yeah,
Fantastic.
and I did correct him for quite some time, and then now I just roll with it.
You're like, yeah, this
So
one
anytime,
this one had a cavity today.
No, but anytime he has a tooth problem, like, why are you asking me?
Oh my God.
Because you're a dentist.
But would your
There's so
kids?
many more
But would your
things,
kids
yeah.
say like, my mom's a nurse?
No, they say I'm a doctor.
Okay.
Yeah, because I mean and I used to correct them, and
Yeah.
then the 5-year-old, there's no
Yeah.
need.
Yeah.
Later in life, I will explain
Explain all the things. Yeah.
things.
Sit down, buddy.
Yeah, sit down. We're just gonna have a long talk. Yeah, because there's not that many CRNAs.
Yeah.
I hope that number goes up, but we did lose quite a few during COVID for whatever reason, retiring. Or just this isn't for me.
But did you
nursing in general.
Did you see the burnout factor? Because in nurses, again, I'll draw the parallel with nurses like huge mass exodus during COVID. Did you see that with CRNAs? I didn't really see it with PAs. I saw it in our profession at our current facility.
Well,
but I don't,
not out of them choosing to either necessarily.
Well, circumstantial, but
so I'm about to give out some information that most people don't know. So I was at a major hospital during COVID. And what happens during COVID is elective surgeries get canceled, right?
oh yeah,
Because
we know.
Mm-hmm.
we know,
Yeah,
right?
we know, yeah.
And that is the moneymaker of the hospital. Well, when you have anesthesia staff that you have to pay, but you're not doing the surgery, the anesthesia staff gets furloughed
Yes.
and a pay cut.
So that's what happened with the ortho PAs, because when you don't have elective surgeries and people can't play sports, then your urgent care PAs don't need to do anything, nor do your surgical PAs.
Yeah, trickle effect, right?
Yeah.
So the people that they did voluntary furlough first, obviously, right?
Yeah.
So most of the, soon to retire CRNAs were furloughed. Some of those didn't come back, right?
That makes sense. Yeah.
I think that the 1099 CRNAs, people that are not W-2'd employees, had a really hard time there because they were the first ones to be furloughed, right?
Yeah.
Because they're not W-2 employees. And, that's a whole nother ballgame that I won't get into. But I think the soon to retire 1099 CRNA is also retired. I don't know of many who, we've gone this far in our education where we just stopped doing what we did,
Yeah.
I do know several nurses that did. I think we lost about a third, was the estimate during COVID.
That's so
of the
much.
profession. And I don't mean like they died. I mean like they.
No, yeah.
Right.
I know one that's one of my good friends who she's like, you know what? I think I'm done. She was a nurse for 8 years. She's like, I just don't want to go through this again. And now she's like a manager at a landscaping group and gets paid more.
And probably very happy.
Yeah.
And probably very, very happy about it, right? So I think with anesthesia, I think it was more along the lines of people that were ready to retire or close to retirement that were like, you know what?
This is it.
I think this
Yeah.
is it.
Yeah, this is it.
I don't want to be a part
I was
of this,
looking for
really.
a sign, and then that was it.
Yeah, that's it.
Yeah.
Yeah. I think computerized charting also took out a few, but that was before COVID.
Yeah. EMR. Yeah. Interesting.
So, but I will tell you that we all, if you worked in a hospital setting at least, we saw some stuff that like I'd rather not ever see again.
Yeah.
Just some weird and just
Yeah.
kind of craziness. But I did take a 30% pay cut for
Ooh, that's
a period
significant.
of, I think
Yeah.
it was like around 3 to 6 months, somewhere in there. I can't remember the exact time.
Ugh.
But I was also working day, night, and overtime.
Yeah.
When people think you should get hazmat pay,
Yeah.
we're getting a pay cut.
That's
Oh
crazy.
my gosh.
So we're expected to keep up all the critical care stuff of the hospital, like proning patients, which ICUs don't usually have to do.
Yeah.
But you do in that kind of a respiratory
Oh my God.
issue. And so we
took a pay cut
took a pay cut.
and dealt with like all the crap of
Yeah.
I know. I have a tremendous amount of respect
With
for
no back pay.
CRNA.
Insane.
I know. No back
So
pay.
I
Why
feel
would
bad-
we do that?
I feel for the government employees right now.
Yeah.
Oh my God.
That's crazy.
That is.
So-
Yeah.
Good. Well, that was a great,
Yeah.
that was a great episode. I feel
Yeah.
very good about it.
Yeah.
I feel good about this.
Okay. Well, thank you for your time, and thanks for enlightening us on what is your fault and what is not your fault.
Nothing
Full
is
moons are not my fault. But
But-
put that out there.
nothing is Emily's fault.
No,
Yeah.
but more importantly, I think that gave a nice little snapshot into your career and your experience, and why you're important and why we love you.
Yeah.
Oh,
me too.
thanks, guys.
Me too.
You're welcome. Okay. Till next time.
Till next time.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.